Hi, my name is Brian Gross. I'm an otolaryngologist, head and neck surgeon at Lewis Gale Physicians in Salem, Virginia. Today, I'm going to be speaking to you about the evaluation and management of patients with thyroid nodules. Thyroid nodules are a common clinical problem. We can find palpable nodules in about 5% of women and 1% of men. High-resolution ultrasound detects thyroid nodules in about 68% of the adult population. Whenever we evaluate a patient with thyroid nodules, our biggest concern is, could the nodule be cancerous or is it benign? Overall, about 5 to 15% of nodules are cancerous, with the most common type of cancer being well differentiated. Thyroid cancer is still common though. Data from 2019 showed about 52,000 new cases of thyroid cancer that year. As you can see on the graphs at the lower on the lower part of these slides, over the past 25 years, the incidence of thyroid cancer has nearly tripled, and almost all of this increase is due to papillary thyroid cancer, and mostly papillary thyroid cancer less than 1 centimeter in size. Studies predict that by 2020, thyroid cancer will be the third most common cancer, and by 2030, the second most common cancer, right after breast cancer. Interestingly, though, despite the increased incidence, the mortality has not increased. This overall shows the relatively indolent behavior of the majority of thyroid cancers. So as I said, when we evaluate a patient with thyroid nodules, the biggest goal is to exclude cancer. But other things to consider are potentially to improve symptoms such as difficulty swallowing or shortness of breath, which are called compressive symptoms, cosmesis, and sometimes the nodules can produce thyroid hormone, and we need to treat the thyroid nodules in order to treat the hyperthyroidism. At first evaluation of these patients should include a comprehensive history and physical exam, focusing on changes in the nodules, as well as any personal history of radiation, mostly to the neck, any family history of thyroid cancer, or thyroid cancer syndrome. The next studies to consider include a thyroid stimulating hormone level, as well as an ultrasound. If the thyroid stimulating level comes back low, this suggests that the patient is hyperthyroid, and those patients are next evaluated with a radioactive iodine uptake scan. For patients that are euthyroid or hypothyroid and have thyroid nodules, a radioactive iodine uptake scan is really not indicated. That is in contrast to 5 or 10 years ago, when that was commonly used to determine patients that needed further evaluation. For the patients that are euthyroid and hypothyroid, we're then really using the ultrasound as well as appropriate needle biopsies to determine management. Ultrasound then is really the workhorse study. As you can see on this slide, there are concerning findings like solid, hypoechoic, irregular margins, etc. And there's also less concerning findings that are such as cystic, spongiform, or if they're iso or hyperechoic appearance. The appearance of these helps determine who needs a biopsy and then to plan long-term follow-up. There are different reporting systems that have been used to aid in decision-making. For example, the American Thyroid Association published this table that groups nodules into risk categories of high, intermediate, low, very low suspicious, and benign. This table uses the ultrasound features, as we just discussed, to then determine the estimated risk of malignancy, and then as you can see on the far right, which nodules need needle biopsy. This table is very helpful, but it is very hard to read. It is a lot of information, and it's hard to interpret when you get an ultrasound report. Fortunately, the American College of Radiology came up with what's called the Thyroid system in 2015, and this has been well documented and well researched. This again uses the ultrasound characteristics of composition, echogenicity, shape, margins, and any presence of echogenic foci to help get a scoring system to then plan the patients that need the future biopsy and additional follow-up. We then give them a score and a level of TR or TIRADS 1, 2, 3, 4, or 5, with a 5 being the most suspicious. All of this data can then be used to determine who needs a needle biopsy. As you can see, over on the left is the American Thyroid Association, in the middle is the American College of Radiology Thyroid system. So for a TIRADS 5, which is the most concerning, you need a biopsy at 1 centimeter nodule. For a TIRADS 4, greater than 1.5 centimeters, and a TIRADS 3, greater than 2.5 centimeters. We'll also often pick up thyroid nodules incidentally on PET scans. PET positive nodules are much higher risk, and the majority of these should have a needle biopsy. Once the needle biopsy is performed, the pathologist will then be able to evaluate the cytopathology. And then they use the Bethesda system for standardized reporting of the thyroid cytopathology. You can see on this table, it's a Bethesda category 1 to 6, with a 1 being non-diagnostic, up to a 6 being malignant. This table also shows the risk of malignancy and the action that is necessary based on the Bethesda categories. We also have to follow patients throughout most of their life if they've been identified with thyroid nodules. Historically, patients were getting ultrasounds every 6 to 12 months. But fortunately, again, with the Thyroid system and the American Thyroid system, we're able to better determine how frequently we perform ultrasounds. Also, in a patient that has had already had a biopsy, as you can see on the right side of this table, we continue to need to follow these patients even when it's benign. And what we're looking for on the repeat ultrasounds is growth in the nodules or a change in the characteristics with concerning features such as irregular borders and echogenic foci. And that will then warrant a repeat needle biopsy. So after we get all this information together, some of the patients need to go on to have surgery. For thyroid cancer, it is the approach to thyroid cancer surgically has changed too. Historically, patients underwent a total thyroidectomy, and a lot of them had adjuvant radioactive iodine. That's changed though, and we're doing less now. So total thyroidectomy is still indicated, especially in patients with larger cancers, greater than 4 centimeter, extrathyroidal extension, or nodal or distant mets. We'll consider just a lobectomy, though, in cancers that are less than 4 centimeters without the above features. Some patients we can even consider observation despite the diagnosis of cancer. There are many studies out that are starting to show good outcomes in patients with small, low-risk, well-differentiated thyroid cancer. We also need to consider the neck in the surgical treatment, whether it be the middle or central component or the lateral neck. Adjuvant therapy is sometimes necessary, whether it's radioactive iodine, thyroid suppression, radiation, chemo, or targeted systemic therapy. We'll also perform surgery for conditions of the thyroid other than cancer. Sometimes patients with hyperthyroidism or Graves' disease will undergo surgery. Some patients want to avoid further imaging, biopsy, and worry, and will perform surgery on those patients. We also, for substernal goiter, in patients that have compressive symptoms or a large goiter that has cosmetic side effects. Importantly, though, is that patients with thyroid nodules need a very personalized approach. When the patients come to see me and they've been told they have a thyroid nodule, they're scared. They don't understand if it's cancer, if it's benign. They know they have an abnormal growth. So part of my job is to educate these patients and then provide them the appropriate care. They also may have heard that in the patients that are diagnosed with cancer that this is the right kind of cancer, but it's still cancer. And all the nodules can behave differently too, despite the size. Some of the smaller 0.75 centimeter nodules, they're not all the same. The bigger nodules are not the same, and not every cancer is the same, despite the size. So since I have been here over the past 5 years, thyroid surgery and appropriate management of patients with thyroid and parathyroid problems has been a major focus of mine. I've performed about 340 endocrine surgeries over the last 5 years. Some of the major complications that we monitor in thyroid surgery or endocrine surgery as a whole is damage to the recurrent laryngeal nerve that can cause hoarseness. The national average of permanent damage to the nerve is around 3%. Mine is at 0.9%. We also closely monitor hypocalcemia as it relates to damage of the parathyroid glands. The national average of that is 2%. Mine is at 0.29%. I've also performed 95 cases of thyroid cancer, the majority of which have been well differentiated and a 0% disease-specific mortality. I have had 4 cases of poorly differentiated thyroid cancer that can behave much more aggressively, and my rate is at 75% survival on those. I had 31 substernal goiters and 1 that actually required a sternotomy to completely remove the enlarged thyroid. So in summary, thyroid nodules are very common. The thyroid stimulating hormone and ultrasound are your workhorse studies. This helps us to determine who needs a fine needle aspiration biopsy, which is then reported based on the Bethesda system. Patients with thyroid nodules and thyroid cancer need long-term follow-up. And ultimately, we're here to provide an appropriate, personalized approach to these patients. Thank you for taking the time to listen to this. On this last slide, you can see our office's address and phone number, as well as my personal email and personal cell phone. Feel free to reach out to me. I'm happy to discuss any of the above.